Alrighty, so today we'll be talking about the celiac trunk and portosystemic anastomoses and some bugs related to that. And we're going to end with hernias. Nice way to end our night. So let's get started. So we're going to start with the celiac trunk. So I'm going to first ask you guys if you know the branches of the celiac trunk.
We got the left gastric, the splenic, and the hepatic.
Yes. Correct. So we have the left gastric, the splenic, and the common hepatic, as you see on the diagram there. And these are the main blood supplies to the stomach. And then some of these, or branches of these, will anastomose, where you see the arrows pointing towards each other on the lesser and greater curvatures. Do you guys know what constitutes these anastomoses? What are the names of the branches?
Right and left epiploic and the right and left gastroepiploic. Oh, no. It's right and left gastroepiploic and superior and inferior hepatoduodenal. Pancreatic duodenal.
Well, you see, you have the epiploic, right? But the other ones, you can see where the left gastric connects to another side.
Right and left gastric?
Yes.
Okay.
It's going to be our left and right gastroepiploics and left and right gastrics. Pure and simple there. With our left and right gastrics being on the lesser curvature and left and right gastroepiploics being on the greater curvature. And yeah, so I'm also going to, let's see here, quickly run through this diagram here. So we talked about the three original branches of the celiac trunk being the left gastric, the splenic, and the common hepatic. And then the common hepatic splits into the proper hepatic and the gastroduodenal. And then from there, the gastroduodenal splits into the pancreatico-duodenal branches, both the anterior and posterior, as well as the right gastroepiploic. So makes a nice little circle there. And then our splenic branch is the one that splits into the left gastric epiploic as well as the short gastric that we kind of see sticking out just a little bit over there. So the reason I go over this is because on the next slide, I'm going to quiz you on it. Woo. Okay, so one more time, the three branches of the celiac trunk.
Common hepatic. Right gastric.
Maybe the left gastric.
Left gastric. And
one more.
I forgot.
Splenic, yes. So, the common hepatic splits into what two things did I say?
The right gastric?
Not yet. It's going to split into the proper hepatic and the gastroduodenal. And then the proper hepatic is going to split into what Pete just said.
Right.
Right gastric, right. And then our gastroduodenal is going to split off branches to the anterior and posterior pancreaticoduodenal branches, as well as
right gastroepiploic.
yes. And then we have our splenic branch, which will also have little branches off of it. You guys know what those ones are that we mentioned earlier?
Short gastric.
Short gastric, as well as one that connects with the right gastroepiploic, as we see with the little arrow.
Left gastroepiploic.
Correct. Awesome. So, what do all of these supply? So, the left gastric and the right gastric together supply what part of the stomach?
Spleen. Oh no. Last element.
Yeah, the lesser curvature. And then your other anastomoses, the right and left gastroepiploics, are going to supply.
Greater.
Yes, greater curvature. And you have your proper hepatic, which is going to supply.
Liver.
Yes, your liver as well as your gallbladder. And then your pancreaticoduodenal, I wonder what they're going to supply.
Duodenum. Pancreas.
Yes. And then we have our splenic branch going all the way to supply the
Spleen.
spleen. And then our short gastric is going to supply.
Fundus of the stomach.
Correct. Fundus of the stomach. Cool. So, any questions on this before we move on? Nope. Alrighty, so now we're going to talk about Portosystemic Anastomoses. More quizzes, yay! So,
Oh boy.
there are 3 sites of anastomoses that we care about in this diagram, as well as a 4th site that we have marked for a procedure that we'll talk about a little more later. But starting with the ones on the diagram, does anyone know this pathway of shunting that happens here?
Number 1, you mean?
Mm-hmm.
We're going to get esophageal varices from liver backup. So it's the submucosal veins of the esophagus that get backed up because the IVC is backed up.
Yes. That is correct. Do you know what veins get shunted towards the esophageal veins?
So it's the left gastric veins in systemic circulation, but it's the submucosal esophageal veins in the portosystemic circulation, or the portal circulation.
I think it's the other way around, but yes, it's the left gastric from the portal, in the purple there, to the esophageal vein in the blue, and then you can also include azygos vein going up through the IVC. Okay, and then we have our second guy over here. We're going to pretend this circle is a belly button, apparently, so that gives you a little hint as to what veins are involved here.
Umbilical.
Yeah, so you have the para-umbilical veins from the portal system, and they go to which veins of the systemic?
Internal ileum or common.
They are actually directly going to first connect to the epigastric veins.
Oh, okay.
So the paraumbilical around the umbilicus to the epigastric veins before going into the iliacs. Okay.
And Hepatic do so.
And then the third set that I did not mark with the number 3, but you can guess they're right there, involving the colon here. You guys know what veins are utilized there?
I know you've got this superior and middle rectal veins. Or is it inferior and middle rectal veins?
It's middle and inferior.
Oh, okay. Middle and inferior.
And then you have your superior right above them, leading in from the box right underneath superior mesenteric vein, inferior mesenteric vein. So you have the inferior mesenteric from the portal venous system going down to the superior rectal vein, and then they anastomose with the middle and inferior rectal veins to go back up to the system. And there is a treatment procedure that can be done to help relieve portal hypertension and reverse these shunts. You guys know what the name of that procedure is?
I do. TIPS procedure?
Yeah, the TIPS procedure. And what does TIPS stand for?
Transjugular intrahepatic portosystemic shunting.
Correct. So that'll be our number 4 guy over there, which we will go into a little bit more depth later. If you go ahead and click one more time, I have a few more questions for you guys. I know you've already mentioned some of these, but just to have a visual review of it. So we talked about the first site of anastomoses at the left gastric and esophageal veins. The clinical sign for this is what it presents as.
Varices.
Yes. It's going to be our esophageal varices, which can easily rupture, and we're worried about hematemesis. And then at the umbilicus, what are we going to see with? Yes, caput medusae. So kind of like snake-like stringy thing going on over there. And then at the rectum, what are we going to see there?
Hemorrhoids?
Well, specifically for this one, if we got esophageal varices up here, down here, we're going to have...
Rectal varices?
Yes, rectal varices. And then, once again, so you can see it with the words, number 4 marks the treatment with the TIPS procedure between the portal vein and the hepatic vein, so we can relieve the portal hypertension by immediately shunting the blood to the systemic circulation. And this can cause a problem known as...
Hepatic encephalopathy?
Yes, hepatic encephalopathy. So, if we actually go to the next slide, what the heck is hepatic encephalopathy?
Increase in ammonia.
And that would lead to... Kind of left it up there a little bit.
What then?
What does this ammonium do to us? Ammonia do to us?
What was
That's
it?
encephalopathy itself. destruction to the brain.
Sure, pretty much. So with the TIPS procedure, and we're shunting from the portal system to the systemic system, we're not allowing this ammonia to be properly dealt with. It's going straight into the systemic system, so that causes a problem, and you see neuropsych dysfunction, and that can range from disorientation and asterisks, oh goodness, to difficult arousal or even coma in severe cases. Now, there are some additional triggers that can occur to cause this condition. Ones that increase ammonia production and absorption, and ones that decrease its removal. So, can anyone name some of the causes of increased production and absorption?
Like kidney dysfunction?
That's going to be more with problems with removal.
Yeah, that's what I said.
Okay.
Production.
Yeah, I mean, all I can think of is obviously it's urea cycles not using it properly. No.
Could be. The ones that first aid here mentions are dietary protein, GI bleeds, constipation, and of course infection, because bacteria is what we're going to talk about in a little bit, that we particularly are worried about here. And then with decreased removal, Pete mentioned renal failure. This is where we also have our TIPS procedure going on, as well as diuretics will prevent proper removal of this guy. So, if you actually hit one more time, we have most of the ammonia in our body. This is where it comes from, either intestinal production, which is about 50% of where our ammonia is produced, or renal production, which is another major source of the ammonia in our body. And then to a lesser degree, we also have it from red blood cells and muscle breakdown, since it results from protein and amino acid degradation. So that's where we see this guy coming in. And if you hit again, this is where we would normally see how our ammonia is being circulated and excreted from the body, either a urinary excretion as urea or fecal excretion as an ammonium ion, which we will also talk about. So when we are actually before I go into that thought, going back to hepatic encephalopathy, if you hit one more time, how do we treat this condition?
Lactulose.
We have lactulose, and then we also have some.
Rifaximin.
Yes. So we have lactulose and rifaximin or neomycin.
Neomycin.
So lactulose. Can anyone tell me how this guy functions?
Pretty much like it induces lactose intolerance in the patient, so it causes like an osmotic pull and pretty much causes you to poop out the ammonia.
Pretty much. So lactose is it's an insoluble form of lactase, and yes, like you said, it causes a lactase deficiency because it's a bond of glucose and galactose that's a little bit different than lactase, so our body doesn't recognize it too well. So what ends up happening is it gets stuck in our system, and our lovely gut bacteria come along and eat this guy up, and that ends up causing them to poop out ammonium instead of ammonia, which will decrease the pH and have this ammonium trapped in that pathway so it can't get into the system, and then just get excreted out. And then we have rifaximin, rhodamycin, being RNA inhibitors. These are going to target those bacteria that cause production of ammonia. Speaking of which, if you hit one more time, what kinds of organisms produce ammonia?
Urea plasma.
Well, yes, so that is one of these guys, but what do they all produce?
Oh, urease.
Yes.
Positive.
Okay. So these are our urease positive organisms, and you already mentioned one of them being urea plasma. Can you guys name the other ones?
H. pylori.
H. pylori, plasma, serratia, protease.
Protease is one.
Okay. Klebsiella.
So you got the P.
Nocardia. Serratia. Is the C. Citrobacter?
Not that one.
I don't know.
Okay, you got most of them, so that's okay. So we have Proteus, the C is going to be Cryptococcus, H. pylori, urea plasma, nocardia, Klebsiella, and then the S's they mention are epidermidis and saprophyticus. They don't mention Serratia on this one, although Serratia is one of the organisms that produce ammonia. There's quite a bit of our colonic bacteria that do produce ammonia in different amounts. These are just the ones that specifically produce urease and ammonia to a very large degree. So these are the ones that we particularly focus on. So what does urease do, actually?
This one turns ammonia to ammonium.
So this is the one that turns urea to ammonia.
Oh, that's right.
So this one's going to cause an increase of ammonia, which is the bad stuff that we don't want. And ammonium is the stuff that we can excrete without issue. And this will increase the pH, so these guys will have a happier time living in the body there. And also these can predispose to the struvite stones, which are made of ammonium, magnesium, and phosphate. So ammonia, ammonium, these will happen there. And yeah, so any questions on this guy here? Nope. Okay. So then we'll move on to our final topic for today, which is hernias. So let's see here. So a hernia is basically a protrusion of peritoneum or organs within the peritoneum through an opening, usually at a site of weakness. So this, the contents of what is being protruded through the opening are at risk for what?
Is it incarceration, strangulation, and necrosis?
Yes. They're at risk for incarceration, which means they're stuck in there and not be able to roost back, and strangulation, which can lead to ischemia and necrosis. And then complicated hernias, of course you can see here, can present with tenderness, erythema, and fever, causing more systemic problems. So there are 3 main types of hernias. Can you guys name what they are? I actually meant to write them out as you said them, but forgot about that.
Indirect, direct, and femoral.
Femoral is one. With indirect and direct, what type of hernia is that? What region?
Inguinal hernia.
Yes.
And then diaphragmatic.
Yeah. All right. So those are our 3 main types of hernias that we will be discussing today.
Fram with an F.
We're going to start with the femoral hernia, but before we get into that, we have this diagram down here with the ones. I'm just going to have you try and distinguish which one of these X's are the inguinal hernias and which one is the femoral hernia. So our first X that Pete is currently circling over there. Do you know what that one is?
Inguinal?
That is an inguinal. Now is it direct or indirect?
Okay. It is it's direct.
Actually,
lateral to the epigastric, so
Indirect.
Oh,
indirect. Indirect.
Okay, sorry.
So then the other X that we have there is
direct.
Is direct. And then our last X at the bottom is our femoral. Woo! Made it through that one. Okay. So we see where the femoral hernia is in that particular diagram. Can we describe exactly where it protrudes?
Below the inguinal ligament?
Yes. So the femoral hernia is going to protrude below the inguinal ligament and through the femoral canal, lateral to the pubic tubercle, which I think is depicted there. Piece of bone there, maybe. This is, yeah. So this is going to be more common in males or females?
Ladies.
Females.
Females with the femoral.
Yes. Got the fem and the fem. And what type of hernias are most common overall, though?
The indirect inguinal?
They actually just say inguinal. They don't mention which one of those two are. Okay. And these femoral hernias are more likely to present with incarceration or strangulation than inguinal hernias, just because of where they come out of and what they're stuck underneath. And as far as the inguinal triangle that we see in this diagram here, do we know what composes the borders to that triangle?
Epigastric vessels.
Mm-hmm.
The inguinal ligament.
Mm-hmm. We have the name of that muscle that's kind of already on the other diagram.
Rectus?
Yes.
Yeah, rectus abdominis.
So that's what makes up our inguinal triangle, which is what we are going to talk about next in regards to our inguinal hernias. So, where did I lose my place here? Okay, so the inguinal hernias, we talked about there's a direct and indirect divisions of these. The indirect one goes through where?
Inguinal canal?
Yes. So this guy will go through the inguinal canal or the inguinal ring and through the external ring and into the scrotum. It's going to follow the path of the descent of the testes in males. And this will enter the inguinal ring medially or laterally to the inferior epigastric vessels.
Laterally.
Yes. So these will be lateral. And this guy can occur in infants since they can have a failure of the processus vaginalis to close, which I will ask that question in a little bit. But before then, since these follow the path of the descent of the testes and go through both the internal and external rings all the way to the scrotum, could be anywhere along the path, they're going to be covered by what?
Spermatic cord?
Yes. So these guys are going to be covered by all 3 layers of the spermatic fascia, which will, its importance will make sense once we talk about direct inguinal hernias, because that's where these two also have a difference. And then going back to failure of the processus vaginalis to close, that can cause a condition known as
Cryptorchidism?
the one I'm looking for here is hydrocele. So you have a communication with the fluid in your pelvic abdominal region coming on down into there. Okay, and then these guys are more common in males versus femorals, more common in females. Okay, so then we have our direct inguinal hernias, and these protrude through, what was the name of that triangle? I remember.
Inguinal?
Sure. Inguinal triangle.
Also I don't know.
Yes, both of those are correct. Inguinal triangle,
Okay.
also known as the Hasselbalch triangle. And these will bulge through the peritoneum lateral or medial to the inferior epigastric vessels.
Medial.
Medial, right. So you have the indirect being lateral and these guys being medial to the inferior epigastric vessels, but the direct inguinal hernias are also going to be lateral to that rectus abdominis muscle. So all of these parts of the triangle that we care about here. And as I mentioned before, the indirect inguinal hernia is covered by all 3 layers of the spermatic fascia because it follows the path of the descent of the testes. But the direct inguinal hernia does not follow that path. So what is this guy going to be covered by?
It's the most superficial layer.
Yes. So it's going to be covered by the external spermatic fascia, only that last layer there. And yeah, so the diagram down there below, you can see where that red ring is. That is where the deep internal inguinal ring is, and this is where your indirect hernia is going to follow that path all the way down, collecting the layers as it goes, versus the direct inguinal hernia is going to skip some of those fascia layers and just catch on to the last one as it protrudes through. Then we have one last type of hernia we're going to talk about is the diaphragmatic hernia. This is where you have abdominal structures entering into the thorax. Can be congenital or as a result of trauma, and it commonly occurs on what side of the body?
Yeah.
The left side, correct. And why does it occur on the left side rather than the right side, or more commonly on the left side?
Because we have the liver protecting and the pleuroperitoneal folds finish on the left side.
Yeah. So mainly because we have this nice big liver here that protects the right side. Okay, so within the diaphragmatic hernias, we have subtypes as well. The most common being a hiatal hernia, in which the stomach herniates upward through the what?
GE junction.
It's actually going to be the esophageal hiatus. So, of the diaphragm. So this little circle guy here underneath.
Actually, no, this one.
Yeah, that one. Okay, then we have a sliding hiatal hernia, being the most common of these hiatal hernias. And in here, what is displaced upward? What part of the stomach?
The fundus.
Well, that would be the answer you said earlier, which would be the GE junction. The GE junction here is going to be displaced upward in a sliding hiatal hernia, and I have a image of that for you a little bit later. And then we also have the paraesophageal hernia, where something is normal and something else protrudes into the thorax.
I know the fundus protrudes into the thorax.
Yes.
The GE junction is one of it?
Correct. So here the GE junction is going to stay where it is, and it's usually the fundus that protrudes into the thorax. So if you hit one more time, you can see the difference between these two, where you have that, again, with the sliding, you see the whole junction going through, and with the paraesophageal, it's para being alongside, you have the fundus along the side of the esophagus without the GE junction being protruding through. And then I mentioned that these can be congenital or as a result of trauma. So if you hit one more time, some issues that we can see with a traumatic diaphragmatic hernia. What risks do these guys have?
GERD.
Well, with trauma, what we're concerned about is there can be a risk of strangulation, and these guys can also cause respiratory distress. So that's something we want to look out for. And yeah, that is all I have for you guys today. Any questions, comments, concerns?
Was there something specific for the congenital?
I think that one is mostly you're just going to have a child in respiratory distress because they're going to have abdominal contents herniating up into the thorax, so they'll be compressing the lungs, and you'll have the heart pushed over to the right side. So you'll hear in the vignette bowel sounds in the left thorax and the heart sounds in the right thorax.
Okay.
So that's the presentation in a congenital.